Good afternoon and welcome to Value Proposition, the building blocks needed to transition to new care models, a webinar tweet chat combo from healthsystemcio.com sponsored by Optum. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com and I will be your moderator today. We are having a tweet chat that's currently being hosted by Kate Gamble, our managing editor and director of social media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. We'll also be using our Q&A panel today, so please send in questions as they occur to you. Leave the default set to all panelists, and we will take them later in the program. And you can download the deck using the URL on your screen. It's at the bottom of some of our slides, and it will also be sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to hear from Renee Broadbent, AVP, Population Health Information Technology and Strategy with UMass Memorial Healthcare. And then we're going to hear from Erik Johnson, VP of Health Management Consulting with Optum. Then we'll have our Q&A. So without further delay, I'm going to turn it over to Renee Broadbent. Renee, thanks so much for joining us today.
Thank you, Anthony, and thank you, Erik, for joining us as well, and welcome to all participants. I hope that if you're in the Northeast somewhere that you're safely tucked away in the middle of this snowstorm. So today we're going to talk a little bit about the building blocks necessary to move an organization or your organization to the new models of care. So today we want to talk about a couple of different things, and I hope for you to walk away with sort of understanding a population health framework that can help you get started or perhaps improve your current processes. What are the various programs that support population health and value-based care? An industry readiness survey so that you can understand where the rest of the world is kind of going with this, and talk a little bit about administrative changes and what impact that might have to the process or to your plans. So before we get started, a little bit of information about who we are at UMass Memorial Healthcare. We're the largest healthcare system in Central Mass. We are a clinical partner with UMass Medical School, and we have access to the latest technology in clinical trials and research. They also do some really cool technology things over there as well. There are multiple locations. There's our Worcester, which is our main campus, which is UMass Memorial Medical Center, the University Campus, and Memorial Medical Center. We have a hospital in Clinton, Health Alliance Hospital, which supports the Leominster and Fitchburg area, and Marlborough Hospital. We have approximately 1,600 physicians on our active medical staff, over 3,000 registered nurses, 12,000 employees, and 1,125 hospital beds. We also provide a variety of services by staff that are nationally acclaimed, specifically in the areas of heart and vascular, orthopedics, cancer, surgery, NICU, children's and women's services, and emergency and trauma. And also, most recently, we are the first academic medical center to join Dana-Farber Cancer Collaborative. So let's talk first about a population health management organization. Many organizations try to build a framework for population health management. And what we tried to do was create an organization under best practices that would support the health system moving towards a more population health focused and value-based focused entity. So we have a separate organization. It's internal within the health system. It sits at the system level, and by that I mean we have the responsibility for providing the direction and strategy and implementation of population health and value-based care. And when we talk about system level, we're a large academic medical center, and there are system level services. Many of you will be familiar with this, where there's services that are provided at the system level, such as information services and human resources. So our population health management organization sits at that level, and we have that responsibility. Our program manages multiple programs within value-based care, including a Medicare Shared Savings Program. We are a Track 1 program. We do have a bundle payments initiative. We have several that we do. We have a large commercial population, and we are one of the 6 hospitals in the state of Massachusetts chosen to participate in a Medicaid pilot. Within the Population Health Management Organization, we have a staff of about 45 individuals, and that number varies as we just hired a few more people this week. And that consists of administration, which is the senior executive team, care management, data analytics and reporting, account management for network support and development. So in our administration team, we have a president, we have a chief operating officer, chief medical officer, CFO, and IT leadership, which is me. We have an extensive care management program, which provides care management and navigation to our populations that are requiring that sort of care. Data analytics and reporting for our quality measures and total medical expense that we report out for those populations, and account management and network support and development. So we have a very large, extensive network, and we have a mechanism in place to help support them through these changes and with the programs that we offer. Our organization is comprised of about 1,700 participating providers in Central Mass, and actually that number was just updated because we are growing quite quickly, and my recent numbers are around 2,500. Our beneficiary member count across all of our programs that we support runs about 160,000. So this is the framework that I'm talking about for establishing an entity within a health system to provide these services and help the organization get there. To start off with a definition of what is value-based care, because there's lots of them out there. And I think this is the simplest definition that I think describes everything. And it's the transition of fee-for-service to one that provides reimbursement tying payment for quality to the delivery of care. We often refer to as shifting from volume to value. So, you know, where we were all fee-for-service, we are now shifting to quality. And everybody's sort of in the middle of all that. But I think that this definition describes that accurately. This slide was provided by the Department of Health and Human Services, and it kind of gives you where they are thinking in terms of where we are going with how our fees are reimbursed. And if you look in 2016 to the left, you'll see the distribution, the alternative payment models, which are the higher risk-based models, and links to quality are a little bit smaller. And if you go to the right, you'll see 2018, there's a significant shift in the APMs, those are the alternative payment models, as well as fee-for-service linked to quality programs. And, you know, 2018 isn't that far away. So they're making an aggressive approach to move us in that direction. So what do you have to do? You have to create a transitioning environment. And there's a lot of things to keep in mind when moving an organization, especially one of this size and to this sort of model. One, if you look to the left side a little bit, we talk about the transitioning isn't easy. There's a lot of culture changes, thought process, education that has to go into really getting people comfortable and transitioning. Time's important. This isn't going to happen overnight. You're not going to just all of a sudden be able to deliver this value-based care. You're going to have to really thoughtfully plan it out and do a lot of culture and education. One of the things that's hugely impactful is having support from your senior management team. So, and when I talk about senior, I'm talking about the highest level executive. It has to be endorsed from that level in order for it to be effective across the organization. And it must be system level, can't be one-off. So you can't have pockets of in the organization sort of doing their own population health thought process. It really has to be a collective effort. Organizations need to become comfortable with an increasing appetite for risk, because that is where we're going. The complicating factors in this process include the changing regulatory landscape and some of the recent administration with the new president. The complicated regulatory landscape has kind of been the bane of our existence in healthcare. There's a lot of uncertainty. It's not a comfortable place for people to be, but it can be accomplished with some basic frameworks and strategy planning. Some of the things influencing this transition are referenced in the graph that's on the right side of this page, and you'll see a number of things, including, you know, the consolidation and integration of hospitals and other entities, reform, value-based reform, new delivery sites, so urgent care centers, increasing competition, things shrink. There's a bigger demand, a bigger pull on not only your physicians, but on your patient population. And a whole focus on care delivery reengineering. So those are all the components that are putting us towards this transition. The first thing that I think is really important that often gets neglected in a lot of things, and this one included, is to have a business strategy to help guide you through this process. Given the complexity and the number of programs, which I sometimes refer to instruments, regulatory, quote-unquote, opportunities, you do need a carefully crafted strategy to be created and to be able to be executed and supported against. You need to vet this thoroughly. Again, this will go back to codifying that plan at the most senior level so that you have endorsement when you need it. It should successfully address the various components associated with value-based care and population health. A key thing is to remain flexible as things change and modifications will be likely. Sometimes from an IT perspective, that's hard for us to be super flexible really fast, but it is important that you do remain flexible because there are things that will be outside the control, such as the regulatory landscape, administrative changes, so your plan has to have that built in. And it needs to have some basic components, including care management, data analytics and reporting, a patient-centered approach, which is now being called consumerism because patients are getting more thoughtful about where they're getting their services. You have to have network strength, and when I talk about network strength, I'm talking about your physician network, getting them together, providing a value proposition for participating in data. Meaningful data, useful data, data integrated from a variety of sources. We talk about the terms big data, lots of data. I'm talking about having all the data that you need that you can actually manage, and that comes from a variety of sources, and it has to be meaningful. So we'll talk a little bit more about that a little later. So one of the things that I like to show is, one of the things I like to demonstrate is a visual framework. And I particularly like this slide because what it does is it puts a framework in that kind of looks like a house. And if you look at the very top of the framework, you have governance, operations, and organization. And then within each of those, there's categories of growth, clinical integration, and value strategy. And within each of those, it covers all the areas that we'll be talking about, the population health, quality and safety, and care coordination, with financial strength and capital foundation as the basis for that. But the most important part of the slide, mostly because I'm an IT person, is the foundation, and that is the population health, information technology, and data infrastructure. That is the foundation of our house that supports all of those other components. Each of these functions within this has a number of tasks and subtasks associated with it. So this certainly doesn't represent a detail, Fran, but it gives you a visual. So if you're helping your organization become acclimated to what this looks like, I like the way this visual presents, specifically as it points to the IT pieces. So let's talk about a little bit about those IT pieces. So we talk about interoperability, and while it isn't that fully achieved, it's vastly improved. We're starting to move towards that direction with more cooperation with vendors and consistent protocols. You have to ensure the access and timely delivery is available to the caregivers. It's critical to achieving that. They need to have the information in order to provide that clear. You need to integrate your claims and other data so that they have a fuller picture. Claims data is great, but other information is equally valuable when it's mixed with that claims data. You also need to think about telehealth strategies that align with physicians and patients to enhance care delivery and to help avoid unnecessary costs. Care management, you need a comprehensive care management program. It's got to be robust. It's got to be able to deliver and manage the care necessary to the population at risk, especially your high-risk patients and your rising risk populations. And having a robust post-acute care network and process is critical. So for us, we've really focused very heavily on some of these areas that I'm talking about. We do have a robust preferred post-acute program, and we do quite a bit with data analytics to help managing our high-risk and rising risk populations. Data and analytics, you need a lot robust information. Data analytics and predictive analytics are all necessary so that you can understand which patients fall into those categories we discussed under care management. So our analytics solution provides us with a lot of predictive analytics that we then work with our care management team so we can get ahead of those patients that are likely to present down the road with chronic diseases that are more costly so that we can give them better quality care and be more cost-effective in our process. Network strength and the alignment of physician incentives to help with the transition is also important. So your physicians have had a lot put on them over the last 15 years. There's a lot of physician fatigue that's out there. If you want them aligned with you, you've got to create some incentives and some value proposition for them. Why do they want to participate in your value base? Why do they want to contribute to that network? So you have to align your incentives with that. In this slide, we have the conceptual model regarding data and how it feeds the other business entities in the organization. So if you look to the left side, you'll see that, and you'll see UMHC because this is our slide and it has our stuff in it. You'll see where we're getting our data. So we have, UMHC's EMRs, and then we have non-UMHC EMRs. In our population health program, we have an extensive network that resides outside of UMass Memorial proper, about 50% of our population. So we have to provide services on both levels. So we need their data too. When we reference payers, we're talking about the claims information as well as the transmission of that data. How do we get it in there? And then you'll see in the middle slide, we talk a little bit about prepping that data. What do we have to do with it? There's a lot, because the data that you collect is going to be, no matter how much you try to put it in a standard format, it's going to come in different formats, and you're going to have to normalize it. You're also going to have to match it to your patient populations and add that in. And if you can see, once you've kind of gone through all of those processes, it feeds into the other business aspects of your organization, your care management, your reporting and analytics, your business management, and it supports all of those pieces. And I think this is a great conceptual model because you can see that data is critical to your value-based strategy. So I want to talk a little bit now about what value-based programs are out there and what you can participate in. So the first one we'll talk about accountable care organizations. And I think we're all pretty familiar with ACOs. They allow organizations and physicians to form entities that will focus on improving the quality of care and deliver to patients. They're governed through CMS. They offer a lot of different tracks, including those with increasing risk. Many utilize Track 1, Medicare Shared Savings, that's the MSSP, because it has no downside risk, only the potential for shared savings. Often organizations use that for their toe into the water, getting into value-based and population health programs because there's no risk to the organization. There are many ACOs that are out there who are experienced now and are having some success and may decide to move to a more risk-based track. And so CMS very nicely has provided opportunities for you to do that with Track 3s. And new in 2018 is Track 1. And they also have the next generation ACO. But for the time being, right now about 95% of organizations remain in Track 1. We talked a little bit earlier about bundle payment programs. Those are programs that are bundled together for specific services for the entire continuum of treatment. The one that people are most familiar with is CJR, which is a comprehensive joint replacement. Some states that's mandated. Ours, it is not in Massachusetts. However, we do participate in one. We also have several others, such as CABG, we participate in, and we've actually had some very good success with these programs to manage that population. Medicaid ACOs are still similar in construct to a Medicare ACO. They present other opportunities to manage another type of population. In Massachusetts, we do not have a Medicaid ACO as of yet. We are just putting our toe into the water. From this year, 2017 to 2018, the state is piloting, sorry about that, the Medicaid ACOs with 5 hospitals or 6 hospitals. And the value of being in that program is we'll be able to help guide the state in the development of the bigger program, which will go live in 2018. Many will be putting in a bid for getting those programs for next year. There's quite an extensive build out and quite an undertaking. But for now, we have a pilot and we have roughly 18,000 members that will be participating in that. Probably everybody is familiar with patient-centered medical homes, where we focus on the primary care, and it's team-based. Another big area is self-insured, and that's the management of your organization's population. This is a low-risk approach. It's kind of a low-hanging fruit in a population health program to manage your own employees and their costs. And if you look at the risk continuum, it's very low on the risk continuum. The benefit of it is that you can, if you get really good at it, you can then create what they call a direct-to-employer strategy. So once an entity has established this and you have a proven track record, you can actually go out and offer this as a value prop in your organization to those in your network or your catchment areas, and actually become a revenue generator for your organization because you're functioning as a payer at this point. We could have a whole seminar just on that, but it is something that to think about. Of course, we have Medicare Advantage plans, which can focus on enhancing the quality of care while controlling and managing the cost of delivery for that particular program. Pretty popular program right now. So I want to talk about MACRA just a little bit, and Erik's going to get into that. So I'm not going to spend a huge amount of time on that, but I want to talk about it in context of choosing the path of programs that are comprising your population health and value-based program, because it's going to be different from everybody. So if we go back to what are the premise that you have to build the program, you talk about the data, you talk about analytics, you talk about care management, you talk about technology that you need to support that. Well, you've got to kind of figure out the programs that are going to be supported by that. So when you're choosing either MIPS or APM paths, these are some areas you want to think about. You want to kind of think about the financial implication to your organization. So there are upsides and downsides to both. There are risks to both, and you really have to understand what the impact of selecting a path or which one of these programs and what that would mean to your organization. Again, you have to have the IT infrastructure that's set in place. You have to have them to support the performance reporting that is required on them. I can't emphasize enough how important data and IT is in this entire process. It is your foundation. And you have to see what your provider readiness is. You know, we started with ACOs, no risk, because we wanted to get a toe in the water. We wanted to get people comfortable delivering quality versus volume. But CMS has been very clear that they would like us to move towards more advanced payment models. But you have to measure your organization's readiness. And then another thing is cultural readiness. You know, we get back to, does your leadership support it? Can your physicians handle it? This is a lot of education and change, and it's not easy. We have a large academic. We dedicate a huge amount of time to getting out and talking to different boards and different groups just to bring them along. I spend a lot of time even educating in IT to get them along to understand why their role is so important in this. So what is MACRA? MACRA is the most significant transformation in healthcare since the creation of Medicare. It is one of those things that has enjoyed significant bipartisan support. Just some high-level understanding of it. It repeals the sustainable growth rate that are the adjustments to Part B. It establishes the quality payment program to incent the transition from volume to value, kind of consolidates things to make the reporting not so onerous. It gives you two tracks, the advanced alternative payments and the merit-based incentive payments in them. That's the APMs and the MIPS. It streamlines and consolidates current Medicare quality reporting under the MIPS. So kind of the thought there was to try to streamline things a little bit because the reporting for these programs can sometimes get a little bit onerous. The thoughts right now is because it did enjoy such bipartisan support, that it will not go away under the new administration. That's not to say it won't change a little bit, but it's not likely to go away. And so this is kind of a busy slide right now, but this is our slide we use internally to kind of show in a very snapshot way what our options are. So we spend a lot of time educating and providing direction. So you can see at the top you have your quality payment program and you have the tracks, and there are one or two, and that breaks up the programs into the individual tracks. So you'll see some arrows pointing down. We kind of fall into the right-hand side. We have fee-for-service. We have bundles. We are in track one. We are in the process of making a strategic decision if we would like to go into an APM model, possibly track one. And then it talks a little bit about some high-level, what does it mean? You get on the downside risk side, you get a lump sum payment. On the not the down risk side, you get increases, incremental increases in adjustments based on your composite scores. Now, the benefit of being under MIPS is if you're in a track one ACO, under some of the reporting, you get some passes of things you don't have to report on because you are already in that program and you get it as a member of being in the ACO. So it takes a little bit of the burden off there. And I'm sure Erik will get a little bit more into that. But this is how we visualize it to our organization. So I want to talk a little bit about the market overview, and that's kind of just like where everybody is. So many organizations right now are starting down the value-based road. And if you look at the stats on the very weak and the very strong, you'll see that those are probably the smaller categories. A lot of people are, don't think that they're super strong or super weak, but you see everybody somewhere in the middle. They're working on different things. They're trying to get the programs established. You can see that they broke it down to financial, care delivery, and infrastructure, and we're kind of all right in the middle. And I would say we were probably in the middle of those programs as well. It's a work in progress. So I want to talk a little bit about where our EHR is. So if you look at the IT areas of strength, okay, you can see that they've broken down the study into standardization of the EHR, which in our organization we're in the process of doing that. And we also have a strategy for EHR interoperability for our external organizations as well as our internal organizations at UMass. That strategy is in process right now. Data analytics, we're building that out. So these are kind of where the rest of the world kind of falls into that. And again, you'll see the patterns are very distinct. Everybody's sort of somewhere in the middle of trying to build these programs out. So if you're not, you're not there yet, don't feel bad. You're in the same boat with a lot of other folks in that you're still working on it. And last, just to talk about some future considerations. So from my perspective, administration changes. Don't panic. We heard a lot of rhetoric during the election. We're going to repeal. We're going to repeal. And now we're starting to see, well, it's a lot more complex than we thought. We'll have a plan in 2018. So, you're going to hear a lot of information. So don't panic. Come up with your plan and kind of stick with it. Again, retaining your flexibility so that you're able to modify that as you need to. Stay your course, stick with your basic foundations: care management, data aggregation, patient-centered focus, reporting, and analytics. If you can get that foundation down, anything you do going forward, your programs will be able to fit into that. You should identify programs that make sense. There is no one-size-fits-all, so what's good for one organization might not be good for another organization, but you really need to develop that strategy to know what that is. And you should talk about it and putting in some APMs for that increasing risk. Remain flexible in your process. You may have to change direction to be compliant, but that's okay. Nothing is concrete, but you should have that foundation put in place. And also, one of the things that we do is we have a group of folks that just remain current on what changes are forthcoming. There's a lot of uncertainty. There's mixed messaging. Based on what you read on Twitter from our president and from the administration. It's a very, the ACA is a very political football right now. It's really important to have those people who really know this stuff, who stay on top of it to help guide you through this process so that you remain current on it. So with that, Anthony, I will turn it over back to you.
Very good. Thank you so much, Renee, for that presentation. Looking forward to a little Q&A. So now it's time to hear from Erik Johnson with Optum. Erik?
Thanks, Anthony, and thanks, Renee. That was great. I think that was really a nice foundation for the rest of the time that we have here together today. And I particularly liked I think the most important piece of advice that we saw in Renee's last slide: don't panic. I live and work out of Washington, D.C., and I can assure you that's advice that would be well heeded here in my hometown at this point. What I want to talk a little bit about, building off Renee's comments, is how MACRA is impacting, how it should impact and how it shouldn't impact health systems and providers' plans for value-based care. I agree with Renee's assessment of MACRA. It is a tectonic shift in the way providers across the spectrum, both physicians, health systems, as well as post-acute care providers, need to think about their approach to value-based care. So MACRA to us here at Optum is an accelerant. It doesn't fundamentally change the nature of what's been happening over the last 14 years. And I will argue that CMS has been moving in a fairly steady direction for almost a decade and a half towards a value-based payment environment, at least with regard to the Medicare population. It really started with the introduction of the inpatient quality reporting program back in 2003. And that first phase really was CMS's effort to just establish some common measurement criteria and expectations amongst providers with both the IQR as well as the physician quality reporting system. Once we got agreement on what would be measured, then the next phase sort of kicked in with the passage of the stimulus bill now, gosh, almost 8 years ago, which provided most notably the incentives for the adoption of electronic health records and the meaningful use program. That's what we call sort of the infrastructure phase of CMS's movement towards value-based delivery. And then finally, in the aftermath of the passage of the Affordable Care Act, the payment programs started to come online. Some of them are voluntary, some of them are mandatory. What we often say to our health system clients today is that given all of the changes to the PPS, the prospective payment system, whether you want to be paid like one or not, CMS is certainly expecting you to behave like a hospital-based ACO, focusing on readmissions, focusing on post-discharge experience of care by your patients, the mandatory bundles that are now slowly coming online. And now with the passage of MACRA, I think we have a similar message being sent to physician groups. Whether you're part of an ACO or not, you need to start behaving and collaborating like you're in one under these options that you have available to you today. I don't think we're done. I think CMS has certainly made it clear in the run-up to the final rule to MACRA and in the time since the final rule was published last fall that there will be what we consider to be sub-regulatory guidance coming out about new advanced alternative payment models that will be eligible for that designation in the MACRA choice, in the QPP choice that physicians face going forward. It's clear that CMS, if it had its druthers, would like everybody to go in that direction. But physicians do have a choice. And this is maybe the biggest difference from the SGR than anything else. The SGR was sort of a classic tragedy of the commons problem in that it held all physicians participating in the fee schedule accountable for the behavior of everybody else, but it didn't hold anybody individually accountable for their own actions. MACRA and the QPP flip that equation. Now, everybody will be held accountable to their own decisions, depending on which track you choose, and about your behaviors within those tracks. Renee sort of laid out the parameters of what that choice involves, MIPS being the reporting-heavy solution, the advanced APM track being one that's perhaps a little bit more ambitious, but certainly more risk-bearing than MIPS. Just to level set, for the most part, physicians are going to be in MIPS in the 2019 payment year or the 2017 performance year. There are just not enough mature and functioning advanced APMs that are out there today for physicians to attach themselves to. Certainly CMS's intention is to grow that number over time. But as a result, for now, at least in the near term, we sort of characterize MIPS as a problem to be solved and the advanced APM model as something to plan for. There is a lot of concern around MIPS, and I think some of that concern is misplaced. As Renee noted, the MIPS track is really a consolidation and a streamlining of previous reporting regimes that most physicians were already reporting under, that being PQRS, the value-based payment modifier, and meaningful use. For a lot of physicians, for a lot of physician groups, for a lot of hospital-owned physician practices, MIPS will be, at least in the near term, the path of least resistance. For physician groups that have done well under those reporting regimes, there's every reason to believe that they will continue to do well in the future if they continue to improve quality incrementally over time. So in that sense, it's not as scary as a brand new program that might otherwise cause folks to sort of tremble in their boots. But MIPS is a zero-sum game in many of the same ways that the hospital readmission reduction program in Part A is a forced curve. MIPS is a forced curve. It is by law budget neutral. So about half of the physicians in the country who are eligible for MIPS are going to gain on the fee schedule, and about half are going to lose on the fee schedule. So in that sense, it's a little unstable. as we look out over the next few years, that instability is probably going to grow because the penalties and the upside bonuses under MIPS will double over the course of the next 4 years. So by the time we get to payment year 2022, nearly almost 10% of your fee schedule is at risk for your performance. What we will also start to see happen in those out years is that there's going to be a dispersion of performance as the performance threshold starts to increase. I won't get into all of the actuarial science behind the performance threshold, but in the first performance year, that threshold is very low. If you choose to participate in MIPS and you choose to submit a set of quality and performance criteria to CMS, you're almost guaranteed not to be penalized. That's how low the threshold is. As we go out into the out years, that threshold is going to get much higher. And it's going to be much harder for folks to qualify for those high bonus payments that are theoretically available. The advanced APM model, from a fee schedule perspective, is much more stable, as you can see there at the bottom of the slide. Now, the variability around those numbers have to do with the amount of risk that physicians are willing to bear or the ACOs are willing to take on. So the performance bonus under an advanced APM can be significantly higher than 5% if you're sharing in savings that are achieved under these models, but that 5% bonus can also be wiped out if you do poorly. But that's a much more performance-based measurement system, and that is entirely dependent on a physician group's or a collaborative's behavior and performance during that performance year. It is not based on that forced curve, that forced ranking. As I mentioned earlier, we sort of see MIPS as something to be solved for in the short term and advanced APMs as something to be planned for in the medium and long term. MIPS is really a standalone model today, and it exists, honestly, a little bit apart from everything else that's going on in not just the Medicare program, but increasingly in the state Medicaid reform efforts that are underway, including in Massachusetts, as Renee's dealing with right now, as well as in the commercial sector. Advanced APMs, ideally, and CMS is certainly striving to take advantage of this, intends to create some synergies with the other programs that are underway, both in the public and private payer realms. All of those programs do rely to varying degrees on a heavy dose of collaboration across sites of care. I was gratified to hear Renee talk about, for example, the need for a robust post-acute care network. If you're going to pursue value-based care in the Medicare populations that you serve, about 78% of the variability on a per capita spend basis in Medicare is in the post-discharge world. It has to do with readmissions and length of stay in the skilled nursing environment, and the number of home health episodes that are prescribed to a particular patient. That's where the vast bulk of variability occurs. And in risk-bearing models, it's in eliminating that unnecessary variation that is the key to making those models work from an actuarial standpoint. But those models also should be built, and we're increasingly seeing this, to be sustainable and scalable, so they can build year over year on past successes. Under MIPS, not so true. The MIPS calculator is going to reset every January 1st, so there's no guarantee that past performance is going to dictate future payments. It's really entirely dependent on that 12-month window. Clock resets to 0, and if you don't improve faster than your peers, you're going to lose ground on the payment schedule. So we think overall we are seeing, again, a tectonic shift towards risk-based payment in the provider world. Here we're talking primarily about Medicare, but I think this is true across all payers. I don't think CMS necessarily wants to see everybody up at the tippy top of the right-hand corner there under some sort of global cap arrangement, although certainly some provider networks are going to be well positioned to take advantage of that. But it is inevitable, and it has been for the last 6 years, that CMS is moving up and to the right. We see that most notably, honestly, with the imposition of the mandatory bundles over the last 18 months or so. The mandatory bundles, I think, are the one thing that I do believe will be under some high-profile scrutiny under the new administration and with the new Congress, given the Secretary-designate and his views on mandatory bundles. But as we move beyond sort of the episodic risk that mandatory bundles represent and move into the population-based risk that ACOs and provider-sponsored managed care plans represent, we really are dealing with a cultural shift that I think Renee articulated quite well. When you move from taking responsibility for the episode to taking responsibility for the life, that requires a degree of integration from a data standpoint, from a clinical workflow standpoint, and from a financial standpoint in order to make sure that the incentives align with the patient's journey through the healthcare system over a 12-month period of time. And that's why we argue that these advanced APMs provide the greater, more stable long-term value. Almost all of the value-based care models that we've talked about today are premised on two objectives. One is that financial risk. The second is that facilitation and fostering of greater collaboration across sites of care, again, taking responsibility for the life, not just the episode. We see these two themes being integrated across virtually every major payment program that is out there today, even in just plain old vanilla Medicare fee-for-service. We see the emphasis on readmissions, we see the emphasis on the bundles, we see the emphasis on value-based care, which measures 30-day post-discharge utilization. All of those are either explicitly or implicitly risk-based models. The required collaboration that underlies excellent performance across those models does require physicians, hospitals, and post-acute care providers to establish some consistent guidelines and some very transparent reporting requirements in order to monitor performance in ensuring sort of ongoing incremental improvements over time. And that consistency and discipline, I think, is imperative to managing large populations consistently and effectively. It is that unnecessary variability in care that starts to wreak havoc on some of these financial models. That historically has not been a particular concern for a lot of providers who, again, just had responsibility for the episode or the encounter. The advanced APM paradigm, if you will, flips that to reward year-over-year improvement, to reward that consistency of behavior, and to really reward the integration and collaboration across the entire delivery chain of healthcare. This echoes a lot of the key capabilities I think that Renee talked about with regard to value-based care strategy development. You know, when we talk about value-based care strategy development within Optum and with our clients, it's important, first of all, to make sure that we know which populations that we want to serve, how we're going to govern the collaboration that will serve those populations, and what the payment roadmap is going to look like over the strategic planning window, say that 3 to 7 year period where folks are making investment planning decisions. Once that population and that roadmap has been defined, it's important to get the right network in place to serve that population. Understanding, for example, that you have a significant Medicaid population that you're going to be taking risk on requires a different provider network than a sort of a direct-to-employer model might require. Again, integrating that post-acute care model if you're dealing with a lot of Medicare or dual eligibles. Once you know who you're going to pursue that strategy with, then you need to know what to ask them to do. And that's when we talk about our population health management and quality programs. That care management and coordination is so important for the high risk, high cost, high utilizers that dictate whether you actually are able to achieve the financial objectives and the utilization objectives that these value-based care contracts have. And then finally, once you know what to do and who you're going to do it with, making sure that the contracting vehicles that you choose are appropriate. When we talk about enterprise risk and financial management, it's really around managing the actuarial ramifications of these contracts and getting paid for the value that you're generating. One of the things that I think is sort of hidden in a lot of this discussion around value-based care is that value-based care is preeminently a public policy concept with a major focus being on reducing costs to the public programs. That's fine, and that's all well and good, but those costs are somebody else's revenue. And when you start to take revenue and episodes out of the system, well, that's good from a public health standpoint, and that's good from a public finance standpoint. It does mean that hospitals and health systems that have built economic models on keeping those beds filled are sort of cutting out their nose to spite their face unless they're able to develop the contracting vehicles that reward them for the value that they create across the payer and the public programs. All of this resides on a deep analytical and data-driven foundation, as Renee so eloquently walked us through with regard to her system. This is new for a lot of health systems, and while this has been a journey for a lot of providers, particularly since the Meaningful Use program was implemented back in 2011, there's still a long way to go for the vast majority of providers that are out there, particularly independent physician groups who either have not had the incentive, their wherewithal, or the interest in building out the data warehouses and data marts that are necessary in order to track populations, to track performance, and to identify opportunities for improvement. The basic blocking and tackling of getting all of that correct is certainly a challenge, but I don't think it's an optional one anymore for most providers. They need to pursue this aggressively starting about 2 years ago. That sort of brings me to the end of my comments. I'll turn it back over to Anthony to facilitate any Q&A.
That's great. Thank you so much, Erik. I like how you said they better get started about 2 years ago. So, but we don't want them to panic, right? Nobody wants anyone to panic.
Right.
Okay. Let's go to our Q&A. Just as a reminder, if you have questions for Renee and or Erik, go ahead, send them in the Q&A box, the right-hand corner of your screen, and leave the default set to all panelists. We have time for a few questions. Renee, let me start off by asking you, it seems to me, and you touched on this a bit, the biggest understanding or decision as a health system is your appetite for risk, your ability to take on risk, and then understanding the programs enough so that you know which one really lines up with the risk you're willing to take. Can you talk about that a little bit, and then tell me who in a health system is making these decisions? Is it the CEO, the board, and what is the CIO's role? Is it all support? Is it providing information to help make that decision? Or is it to urge and to say, hey, we can do this?
So I think that there's a lot to that question. So, you know, you have to kind of do a temperature check on the organization to see, you know, I would hazard to guess that traditionally academic medical centers are pretty much all the same, and that moving towards more risk is a difficult thing. And so really what we've done is we've really kind of analyzed, you know, the programs that are available and matched them up against financials and what programs we can support, and then socialize that to the organization. And so when you say who approves that, so if you have an accountable care organization, you have a board, and that board is your sounding board and kind of provides that guidance or the feedback or the okay to move forward. We also do socialize this in different ways to the organization, and this ties into your comment about the CIO. So I report to the CIO of the health system, but my specific role and my background is that I was a CIO, but also in population health. So we kind of combine those roles to kind of help guide the organization. So we are taking an active role, IT, in this process in development. And so, for example, in our organization, as we craft our strategies and we map the data infrastructure needs, the data analytics, then we also tie that to the business strategy and then socialize that to things such as the IS committee of the board, which then socializes the board, right? So it's a kind of a multi-prong approach where you have to kind of go get buy-in from a lot of folks. And the CIO is actually, we do have a very, very important role because of the data, because of the infrastructure requirements, because of the data analytics. And so one of the things that we're doing right now in our organization is crafting the system-level data analytics strategy, of which I'm leading. And so that's a very active role for the CIO to be involved in. So it's really, they're not a provider of services, they're an active participant in the formulation of this.
Erik, any thoughts on that?
I don't know if I have a ton to offer that is of value. I will say that in my experience over time, CIOs are getting more and more involved in these decisions, as they should be. I think both Renee and I are big believers that this is a data-driven decision and then a data-driven operation. And healthcare systems at some level are, there's an embarrassment of riches with regard to the data that they get, but that creates its own problems. And knowing which source systems are usable and valuable, and how to translate the transactional data into something that can be analyzed effectively and consistently it's sort of core to making these things work. I think increasingly what we're seeing is, in addition to CIOs, we're seeing chief medical informatics officers reporting into sort of the ACO board to make these things a little bit more intelligent as these decisions get made. They can have a better feel for the types of populations you're taking risk for, and therefore what source systems and transactional data might be available to you.
Very good. One further comment
go ahead.
Just one further comment on that, just to kind of supplement some of what Erik had just said. So in our entity, for our population health management organization, we have a leadership team. Some of us have dual reporting responsibilities. So while I report to the CIO, I also report to the president of the population health management organization. And some of us have that role in there. And I think that helps kind of bridge those worlds that need to be put together. So, our CFO also participates in the governmental programs and understands all that. So I think that has helped us create a very solid program.
Very good. All right, we have a question from the audience. You both mentioned post-acute care in your presentations. I'm seeing many nursing homes still on paper, and the ones that have EMRs have no integration to each other or acute care or ambulatory care. What have you seen is UMass integrated in post-acute care? Renee?
So we actually have a whole program around our post-acute care. We call it our preferred SNF network, and we actually vet those in our programs, and they have to pass a bunch of tests and things like that, and so that they get the 5-star quality. And what we did is we have implemented a commercial product that's specifically geared around this, that alerts us and our care management team. They don't have to have an EMR. And it allows us to know when one of our patients in our program has been admitted to a post-acute facility. That goes right to our care management dashboard and allows them to act on that. And that has been a huge, huge benefit to our care managers, because the ambulatory care managers that generally participate in that have to go to a lot of different systems, and that's an area that needs a lot of work. But we do have a system that we utilize that alerts us for that. Pretty comprehensive. All of our facilities are utilizing it.
Erik, I believe you said there are a lot of issues here between acute and post-acute. So you want to talk about that a little bit?
Yeah, well, I want to be clear. I think there's a lot of opportunity to improve that relationship. And, I like what Renee had to say. I wouldn't get too hung up on the lack of EHRs and SNFs, although that's starting to increase. Because there's so much else to do in getting that relationship right. And I sort of refer to it as, especially in the Medicare fee-for-service population, you're still at the mercy of what the patient, or increasingly the patient's family, chooses to send those folks for their care. So you end up with more sort of a coalition of the willing, folks who are willing to save a bed, willing to agree to certain clinical protocols, and willing to share certain data, even if that's data that's just shared over the phone or by fax. Getting that basic blocking and tackling right with regard to that discharge decision, I think trumps whether there's, I think it's more important than getting the electronic data interchange right today. That'll get solved down the road, but there are other more important challenges.
Excellent, excellent. Well, that's about all we had time for today. When you close out your WebEx window, you're going to be taken to a post-event survey. If you could answer those questions for you, take less than a minute, we'd appreciate it. I want to thank our speakers, Renee Broadbent and Erik Johnson, and very much our sponsor, Optum, for making the event possible. For continuing education issues, If you have the CHIME CHCIO certification, attending our webinars gets you 1 CEU. So let CHIME know you were here, and if you've asked us to do so, we will. If you need a certificate of attendance for another CEU program, you could use the final slide in this deck. You'll receive an email when our archive recording has been posted to our YouTube channel. To produce a webinar on the topic of your choice, you can contact Nancy Wilcox from our team, and you can go to our website to see our upcoming schedule. So great webinar. We could have gone on a lot longer with questions. Maybe we'll put to be continued on this. Again, I want to thank Renee, Erik, Optum, our attendees. Everybody have a wonderful day. Thank you.
Thank you. Thank you, Anthony.
Thanks, Anthony.